Today we are going to discuss about retinal venous occlusive disease. So retinal vein occlusions, which are more common than arterial occlusions, so mainly seen in elderly patients in old age, like 60 years to 70 years. So what is the etiology? So occlusion. So retinal vein occlusion should occur. So it is due to the thrombus formation. So what are the predisposing factors? Age 50, above 50 years of age, and hypertension, diabetes, hyperviscosity of blood, as in polycythemia vera, polycythemia, hyperlipidemia, blood become very viscous. Okay, and macroglobulinemia, leukemia, multiple myeloma due to increase in the proteins, and cryoglobulinemia and hyperhomocystinemia. These are very common. Occlusion is common. So periphlebitis retina, as in case of sarcoidosis, syphilis, Behçet's disease, SLE, and Wegener's granulomatosis. Rise diopy in patients with CRVO and along with the POAG, primary open angle glaucoma. So oral contraceptive pills in younger females and hormone replacement therapy in elderly females, which are common risk factors. Smoking also predisposes to the venous occlusive diseases. So local causes will be orbital cellulitis, orbital tumors, facial erysipelas, and cavernous sinus thrombosis. Coming to pathogenesis, what will happen? The vein will undergo pressure by atherosclerotic retinal artery. So they both share the common adventitia just behind the lamina cribrosa and arteriovenous crossings. So this induces secondary thrombosis in the lumen of the vein. Okay, according to Wittkostrad, what is Wittkostrad is studied in patho, right? So there is a slowing of the bloodstream due to the occlusion, and vessel wall changes will occur due to the damage to the endothelium and changes in the blood due to the viscosity of the blood. So coming to classification of means retinal venous occlusion disease. So this is CRVO. In that CRVO further divided into impending central retinal venous occlusion, non-ischemic CRVO, and ischemic CRVO. Okay. Non-ischemic is venous stasis retinopathy, whereas ischemic is hemorrhagic retinopathy. Coming to another type is in this occlusion disease, we have another type which is branched retinal vein occlusion. It includes hemiretinal vein occlusion, quadriretinal vein occlusion. Hemi means half, quadra means 1/4 of the vein got occlusion. Another one is small branch occlusion. So let's discuss these in detail. Coming to CRVO, main symptoms will be blurring of vision, which is worse on walking and improves over the day. Signs will be retinal vein dilatation will observe on fundoscopy, and tortuous veins will be seen, and we will see hemorrhages, macular edema. These hemorrhages are very small and scattered hemorrhages. Coming to investigations, on optic coherent topography, we will see mild macular edema, and FFA shows increased retinal circulation time. Fundus autofluorescence may show phone-like perivenular appearance. So how do you treat this? Means we should correct the predisposing factors, whether it is thrombus or anything. If it is thrombus, we should dislodge the thrombus, or if the artery is compressing the vein, we should check if there is any CRAO or anything, and we should treat it. Avoid dehydration. So if dehydration is there is a high chance of intraocular pressure rise, so we should correct that dehydration. Okay. So lowering IOP, we should lower the IOP by means of topical beta blockers or topical carbonic anhydrase inhibitors. Carbonic anhydrase inhibitors, they prevent the aqueous formation from the ciliary body. Okay, so antiplatelet agents we should use to lyse the thrombus, and other anticoagulant measures should be tried. So coming to non-ischemic CRVO, it is unilateral, whereas that impending CRVO, it is bilateral. Okay, here you will see unilateral, mild to moderate blurring of the vision. So sudden onset, there it is worse on walking, but here it is sudden onset, non-ischemic CRO. So RAPD is absent, okay, pupillary deficit is absent. So coming to fundus examination, in early cases we will see venous congestion, means vein is pooled off, surrounding full of blood, okay, tortuous veins will be seen. And here also you will see flame shaped hemorrhages, but these are superficial and they are more in the periphery than in the posterior retina. And you will see papilloedema, but we don't see macular edema as in case of impending CRU, okay. So and in late stages we'll see sheathing around the main veins, senioretinal collaterals around the disc, optic disc. We will see collaterals will be arising, so to improve the circulation, and retinal hemorrhages which are partly absorbed through that. Chronic cystoid edema in moderate cases will be seen. Macula will be normal, no macular edema as such in case of impending CRU. So this is non-ischemic CRU. So about 5% of non-ischemic CRU, they will convert into ischemic CRU if not treated in 4 months, and about 30% 3 years. So here you will see non-ischemic CRU diagram. There are many tortuous veins you will observe, and there is no such macular edema seen, okay. Coming to ischemic CRU we will also call it as hemorrhagic retinopathy. Refers to sudden complete occlusion of the central retinal vein, usually occurs in elderly people with cardiovascular diseases. Clinical features are vision loss, which is marked and sudden, RAPD which is present, okay. There is no such RAPD in central retinal venous occlusion. So coming to fundus examination, here also engorgement, congestion and tortuosity of veins are seen in early cases. Hemorrhages are massive, whole fundus is involved, giving a splashed tomato appearance. In non-ischemic and occlusal disease, we just saw flame shaped hemorrhages. In non-ischemic we saw superficial flame shape. Here we are seeing whole massive hemorrhage, just splash tomato appearance. And here you will see cotton wool spots. Here it is, here the whole see fundus which is filled of hemorrhages, okay. This also okay, even temporal branch is involved there. So coming to disc, it shows hyperemia means increased blood flow. Edema also seen. Macular area is full of hemorrhages, severely edematous. So and vitreous hemorrhages will also be seen. Late stages we will see sheathing around the veins as such in non-ischemic, and collaterals same like non-ischemic, and neovascularization may be seen at the disc, okay. Seen mainly in the periphery. Macula shows pigmentary changes, and we will see here chronic cystoid edema. Macula is normal in non-ischemic. Coming to pathognomonic features of ischemic CRU, differentiating it from the non-ischemic CRU. Presence of RAPD. So RAPD is absent in non-ischemic. Visual field defects and reduced amplitude of B wave in the ERG. Complications are rubeosis iridis, neovascularization of the iris. Neovascular glaucoma occurs in 20% cases if not treated in 3 months. Vitreous hemorrhage and proliferative retinopathy seen in few cases. So branched retinal venous occlusion we'll see next part.